So the main speakers, there's 3 of them, they've all arrived. So I'm going to welcome to the fore the incoming SRC President of SMU, your current SASCO chairperson, to come give us the expectations for this event. The floor is yours.
Do you mind speaking by the podium?
Oh, should I stand up? Greetings, everyone. Greetings to our Honorable Minister, to our President of the ANC Youth League, our President of SASCO, all distinguished guests, peers, comrades, good evening. My name is Dilintla Mangwane and I'm the chair of SASCO here in Sefago Makata Health Science University. I'm also a qualified biologist who's I'm currently a first-year medical student here, but today I don't stand here as a student, I stand here as a leader. I stand here as a leader who, against all odds, stepped into a space that has been dominated by men. And I'd like to say, before I can continue, please let me say this without any fear of contradiction, openly so. I want to be the president of this university, and I'm going to be the president of this university. And because I think that leadership should look like the people it serves, right? So it should look like the people it serves, and if a young woman like me cannot rise above academia, it means that our transformation is still incomplete. Let me quote Winnie Madikizela Mandela when she said, "You strike a woman, you strike a rock." I stand before you here as that Imbogoto, upholding the belief that women belong at the very top. So, for today, we're going to talk about the national health insurance. As young people who are starting to become healthcare professionals, we welcome the vision of the national health insurance. And we say that, yes, we agree that quality healthcare should be an access to everyone. It should not be a privilege for the wealthy, rather a guaranteed right for every South African, right? As the words of Nelson Rolihlahla Mandela, when he said that overcoming poverty is not a gesture of charity, right? It's an act of justice. As Dilintla Mangwane, I stand here to say that healthcare, access to healthcare rather, it should not be an act of charity, it should not be a gift, but it should be a justice. So, Honorable Minister, you are here today, we welcome you. But in SMU, we have a lot of issues. I'm just going to touch a bit. Maybe we can address them in line with the national health insurance. So the first one is clinical blocks and rotations. When our students go onto clinical blocks, they don't have stipends. I don't think there's any course here that has stipends. Our students carry many financial burdens. They go to hospitals, they don't have this, they don't have that. So please, we want funding, we need funding. Because at the end of the day, funding is not a charity, it's rather an investment for the future healthcare professionals of this institution. And on top of that, while speaking about funding, the National Health Insurance says it's going to need doctors, nurses, pharmacists, all healthcare professionals, but we don't have funding. I say, please bring back those provincial bursaries. We need them. We need them. We really need them. Because at the end of the day, we cannot just be students. We need to be leaders, right? And I'm here standing in front of you today to talk about, which is the third one, the job opportunities. We lack job opportunities. We know the unemployment rate is about 33.3%, but surely we could do something. Because our young graduates, they go into facilities where there's no proper housing, there's broken equipment, there's this, there's that. But then NHI, if it can fund those very hospitals where we are trained, surely it can make sure that no student drops out of university just because they don't have funding, right? But then let me just leave you with a few words of Drasa Machel when she said that, when she said that we need to dare and invest in the future. When we dare to invest in the future, I hope that everyone will become whatever that they dream of. So I'm daring everyone. I'm daring you. I'm daring you. I'm daring everyone at the back, even you, Minister. Let us invest in a future where healthcare is not only for the privileged, where no student drops out of university just because they do not have money, and where young women rise to the top. Because at the end of the day, preventing conflicts of tomorrow starts with changing the mindsets of the youth today, which is us, the students, the leaders, the dreamers. Because when history looks back at this generation, let it be known that we were not just witnesses to it, but we are the architects of it.
Good evening. Hello. Good evening, and how are you? Yeah, let me recognize the president of the ANC Youth League and the leadership of SASCO. And let me just say protocol observed, meaning all of you are acknowledged. Because in the interest of time, the young lady who was here was already doing my presentation. I don't know why she stopped, because she seems to be understanding the issues. Yeah, the NHI we are talking about, which has been taken by 7 organizations to court, it's about you, it's about your future. It's not about us. Us, our time is passing, and fast passing. Whatever changes we want, it's about you. So you are the ones who should have been more active than even us, the adults. Why now this topic called NHI is the most ununderstood topic in the whole country. I may say in the world, maybe in some countries. It's the most misunderstood, it's the most misquoted. I won't be lying to say 80% of the things you have heard about NHI over the radio or in any media, 80% of them are false and distortions. Because some of the distortions are very deliberate. Others is just outright ignorance. But for people who do not, excuse me, I've got some flu. By people who do not, is there a bottle of water for me? Bottle of water, please. By people who do not understand this, or because they lived in a different era, they do not want change. It's no different from what some of us went through during our time when we were fighting against apartheid. There were black people, some of them our parents, who did not understand what we were doing because they lived in a different era. Now, okay. I can put this away. Oh yeah. Okay, so now it becomes very difficult to convince people and tell them what NHI is. For that reason, I've tried my best to simplify things, to make sure that you do understand, but I've addressed lots of people, students, some of whom, because of the way they were socialized, try to ridicule what I'm presenting and believe I'm lying and what I'm talking about will not happen and all that. Some are angered by what they see in our healthcare system, especially in our hospitals. And because of that anger, they believe what we are going to bring is going to be worse Whereas what you are bringing is to try and solve the situation in which you are, because it's happening because of the absence of NHI. For you to understand, let me start here. For those of you, I don't know how many of you here are in health, but yes, I don't know. But all of you, okay, fine, good. I'm sure you know, or at one stage you have heard about WHO or the World Health Organization. Many people only heard about it during COVID. The World Health Organization was established in 1948 to coordinate activities of health around the whole world, for the simple reason that health, in most instances, knows no boundaries. I'm sure you have seen during COVID. You have seen what happened during COVID, right? It started in China within no time. It was not caused by there, as Donald Trump wanted to say. But you remember it was picked up in China. We had to send a plane to take South African students to bring them here running away from COVID. But a few months after they're here, it spread all over. And it spread all over the world. So diseases too like that. In the 80s, it was smallpox which killed 300 million people. And for it to stop, the World Health Organization had to act globally. Because in health, if you act locally, you will never be able to defeat any disease, especially communicable diseases. So the World Health Organization was formed as an agency of the United Nations to coordinate. And one of its achievements is that every year in May, all ministers of health around the world, we go to Geneva. Even this May, I was in Geneva. We go there to develop policies about health. So when we meet as ministers of health, it is called the World Health Assembly. So we call it an assembly, just like an assembly of students, because every minister of health will be there. But because they are ministers of health, all the experts go to Geneva to lobby ministers of health about certain policies. For instance, people who are experts on smoking and they want us to control cigarettes will be in Geneva. But cigarette companies will also be there, lobbying and bribing and wanting their policies to be adopted. So the World Health Organization is a very powerful organization. Now, in education, we usually assess what you are doing via the results, whether the education system is working very well. We check the results, we check how many students go through matric from those who started school, etc. Now, in health, what do? The World Health Organization gave us a framework that for you to assess that a health system of your country is working very well, you must assess it via 6 building blocks. I can call them pillars. In other words, pillars of a healthcare system. Now, these are the pillars on the wall there. Now, if any one of the pillars is weak, the population will feel it. Sometimes they will get angry, they will toy like you. But they won't know that it is pillar number 1 or number 6 or what that's gone wrong. They won't know. But if any of these pillars goes wrong, the population will feel it. They will start complaining. Like now, I'm going to show you which pillars are problematic. The first one is leadership and governance. I don't have to teach you about that. Leadership is very important. Whether in church, among student politics, at universities, in school, anywhere where you are dealing with human beings, especially those who are many in number, leadership and governance is very important. If it starts shaking, the population will feel it. The second one is access to essential medicines and other commodities. Of course, a healthcare system, you need medicines. If you go to a clinic, they tell you we don't have this and that, we don't have this and that. You get angry. Or you go there, you want to test whether you're HIV positive. They say we ran out of test strips. It means what you call other commodities is not there. Or they say come next week because the X-ray machine is broken. We don't have any other. It's commodities. Or they say no, We don't have this Panado that you are asking for, a cough mixture, etc. So it's important to have this. The third is the health workforce, which you are hoping to be. You are still hoping. You are hoping to be part of the health workforce in South Africa, right? That's why you are here. Yes, you are learning with the hope that one day you will be the health workforce. Now, the health workforce doesn't mean only doctors and nurses, as many of people believe. To run a healthcare system, you need other workers other than doctors and nurses. Just to give you a simple example, if the ladies who are sterilizing equipment go on strike, doctors won't do any operation, even if they want to. And this is an ordinary lady who has not gone to school. She's on strike, but she's holding professors from doing their work. If ladies who are working the laundry go on strike, or if ladies who are, or men, by the way, who are supplying food in the hospital are not there, and the patients are angry, you may even close that hospital. So the health, even at the gate, the security at the gate is part of the health workforce. And that's why we are trying to train them, not to turn back a woman who's pregnant and tell her the clinic is closed. They must know something about that. So is the health workforce or human resources. The fourth one is health system financing. Please, if you are full of play or you want to make noise, I'm asking you just to keep quiet for 5 minutes when I deal with this. You see the color? It's red. It's red. It means there is a problem about healthcare financing. Most of the problems you experience in health is because of this. This is not a problem only for South Africa. It's a problem for many parts of the world, especially poor countries. Certainly for Africa, the whole of Africa. This is a big problem. What do we mean by healthcare financing? We're not talking about the budget only. The financing healthcare is not only about the budget, which the Minister of Finance read in what you call, in Parliament every year. It's not about that only. If it was about that, it would have been very easier. Healthcare financing is a very, very complex thing. That's why people do not understand NHI, because basically the centrality of NHI is about healthcare financing. When we say NHI, we are talking about this pillar. How do you finance your healthcare such that in the population, as the young comrade here said, comrade lady here, such that even the poor can get good access to healthcare, not the rich? How do you do that? How do you make sure that a millionaire or a millionaire's wife and a wife of a gardener, when they are pregnant, they are all able to get good health care? How do you make sure that that happens? Some people say it's impossible. They believe it can't happen. And I'm here to tell you it's not impossible. It depends on the will of a particular country. Then the fifth one is health information system. I must tell you about it because it's important. But you're not kids, man. You're university student, there's no kid here. Woman, those who believe they are kids, man, maybe must understand this is a time of adults, you know. Give us a chance, man. This is an adult thing. Those who are babies, yes. Please. Health information system, let me tell you, especially you who are in the era of technology, it is very, very surprising. That technology is so advanced. You know, when you go on social media, computers, you can do miracles on it. Miracles which some of us never saw when we were students. There were no computers during our time. There were no cell phones. Many of you were born when cell phones were there. A cell phone came in when I was already an old man. So you have got advanced technology. But the surprising thing is, not only in South Africa, many countries don't have reliable health information systems. And what do we mean about that? We don't mean just registering patients on the computer and giving them file. We mean having a system that can trace any member of the population throughout the whole healthcare system. We're talking about a system which, if today you can see I've got flu, right? If I decide to get treatment here, do you have a clinic here? Yes. If I decide to have treatment here because I'm acutely ill and they give me cough mixtures and medicines, and tomorrow I drive somewhere, whether here in Gauteng or to Limpopo or Eastern Cape and all that, I go to see a doctor. Will that doctor know what I was given here? No, he won't. And they can repeat the same treatment. If I don't tell them or they gave me this, especially elderly people who may not know about these medicines, you can keep on piling medicine upon medicine on them without knowing that these people, yeah. I want to give you a story. When I was a GP in the 90s, I was working in Skukune in Limpopo. I don't know who's from Limpopo here. Yeah. 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 Who is from Limpopo? Yeah, no. Yeah, I can see it through your rural appearance. You are from my province. You know? Yes, you're from my province. Okay. Relax. Yes. Now, during that time, in the 90s, in Limpopo, Eastern Cape, in rural province except in Gauteng, there was no way you could diagnose HIV and AIDS. There was no mechanism. Today you can go to any clinic, just prick your finger, and they put you on that strip and they tell you. That time it was not there. Anybody who you suspect to be HIV positive, if you are in Limpopo, we send them here. We used to call it Garangua Hospital before it was called George Mukari. So this gentleman enters my practice, and I looked at him, and I examined him. I suspected clinically that this person is HIV positive. And I knew I've got no way of diagnosing it. Now, during that time, when you send a person here to Pretoria, you apply, unless it's an emergency, you apply and say there is this person, you explain the symptoms, and then after 2 weeks they respond to you, they say you can send this patient on such and such a date. So I did that for that gentleman. I was convinced that he's HIV positive, just clinically, but I needed a test to confirm it. So I applied for him. Firstly, I cancelled him. And after giving counseling, sent him that I'm sending you to Pretoria, to Garangua Hospital. And I applied. And after 2 weeks, the response came. They say, how? But this patient you are applying for is our patient. He has been here many times. We are treating him. He's HIV positive, yes. Why are you applying? I'm trying to demonstrate to you, because they didn't have this system. If it was there, they would have known immediately. But they didn't. So why was the gentleman not telling me I've been in Garangua? Because in the early days, when you tell people that they are HIV positive, many of them, it was unbelievable. So they'll go from one health facility to the other, hoping that one day somebody will say they are negative. Yes, they'll keep on testing. And they can visit 100 clinics doing a test, but nobody will know because we didn't have this. Now, we have gone to CSIR in Pretoria, Center for Scientific and Industrial Research. We said they must get us a health information system which is owned by the people of South Africa, not a private company, where we are going to pay no licenses, which will be used by everybody who is a South African. And it took 8 years for CSIR to do so. We now have a system, but we are still piloting it. We piloted it in the Free State. All the hospitals and clinics in Free State, except 2, are not connected on this system. We call it the HP, Health Record, Health Patient Registration System, HPRS. So this is very important. And many countries, even advanced ones, are already asking us about it. Or you understand in South Africa you have been able to get a system. Can you tell us how it works? So we are happy about it. The last pillar is health service delivery. How does the government deliver health services to individuals? What are the packages? If you are a pregnant woman, what is there for you? Because pregnancy needs to be taken care of. How many times can you see a doctor? What about the gynecologist? What tests are they going to do? Can they put the child under a scan to see whether the child is developing normally or whether it's got a problem with the nervous system or any part of the body? Not what is happening now, where people travel distances to put a pregnant woman under a scan to see the sex of the baby. I'm sure you are aware by now that that's a useless thing. It's useless. What's the value? Medically, what's the value of knowing the sex of a child and pay exorbitant sums of money for that? But people are paying huge amounts of money, and doctors are obliging, even when they know it's valueless. At the moment, when you are a medical student, because money is not controlling you, you'll know how much valueless is this thing. But when you complete, you are going to be some of the conspirators. When you start opening your practices looking for money. For now, you are pure and innocent. When you go out there, the innocence come to an end. And you put poor women under a scan and make them excited and charge them 500 rand. Just seeing the sex of a baby. That's not important. The important thing is, how is this baby growing? Is the baby normal? Is he going to be a normal member of society, etc.? That's a health service delivery. Now, at the moment, if you ask me, if I put two women here and they are pregnant, and I ask what are they going to get from the health service delivery, it will depend which one of them has got a medical aid. It will depend on that. The one who has got the medical aid, the path is clear. It's going to be put under scans. They will do all the blood tests. They will check the baby. They will sue specialists. If the other one is just a domestic worker, there is going to be a problem. Not that she won't be taken care of. She will, but I'll show you where and what are the difficulties. If you are HIV positive, what does the healthcare system have in store for you? Or if some of you here might have been born with diabetes type 1, which means you are born with it, you get it in childhood. For you to arrive at my age, what must the health system give you? Because you can easily collapse and die, you can have complications, we can amputate your legs. It's very problematic. But what is the health system having for you? That's the health service delivery. So these are the 6 building blocks. Now, before I move further, I want to deviate and go here. Back in 1978, the World Health Organization and the United Nations Children's Fund called a conference in a place called Alma-Ata. Alma-Ata was in the former Soviet Union, which most of you who are real activists will know about. There was something called the Soviet Union, which disintegrated in the 90s. Inside the Soviet Union, there was a small town of Alma-Ata. The World Health Organization, together with UNICEF, called a primary health care conference. It was attended by 164 countries. They were going to talk about health of the world. And that conference did 3 things. 1, they defined health. At the present moment, if I were to start here, even if you are medical students, even if I bring doctors and professors here, if I ask them one by one what is health, I'm going to get as many definitions as there are people here. But in 1978, the World Organization gave a global definition of health, which many people in South Africa are refusing to use or pretending it does not exist. Because health, they said health. In other words, they were reaffirming the Constitution. They were not just starting from the beginning in this conference. They were reaffirming the Constitution of the World Organization, which was drawn in 1948, which said health is not just the absence of disease or infirmity. but must be defined in three things. When you say somebody is healthy, like now, you can see I'm not healthy. Because I'm coughing a lot and you are laughing at me. I'm sneezing and all that. Yes, that's physical incapacity. I'm physically incapacitated. And many people end there. For how you are sick, you take your medical aid, there's a hospital there will fix you and all that. That's not health. The World Organization said health is three things. One is a state of good physical, yes. Don't be coughing like me and all that. But also a state of good mental well-being. And thirdly, good social well-being. Now, in this hall, I'm the only one who is coughing and I look sick. There are many of you here who are sick. You don't know about it. Yes. 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 That is mental well-being. And mental well-being doesn't mean you are mad, as many people think. No, you could be grieving. You could just have received a message that somebody has died at home. It is going to disturb you. You could have lost a parent. Yes. Your father could have phoned you and told you he has lost all the cattle he owns and all that. Yes. You are not going to be balanced. You are not going to concentrate. That's mental well-being. Yes. And the last one is social well-being. Now, social well-being, many governments don't like it around the world because it means many things. It means you having education. There are many people who are not having education. It means you having clean running water. It means you having sanitation, electricity, food, and nutritious food to eat. Those things must be looked at when you are providing health care in any country. So it's three things: a state of good physical, social, and mental well-being, not just the absence of disease or infirmity. That's number one. Number two, they declared health as a fundamental human right, and that we must strive to attain it. Now, I'll tell you the significance of that. When you declare something a fundamental human right, you then cannot turn and say that right must be bought with money. It's no longer a right. In other words, you can't say health is a fundamental human right, but only those people who have got enough money will get good health care, as is happening now in South Africa. It's no longer a right. Number three is this, the second article. I want to read it as it is. It says the existing gross inequality in health status of people, particularly between developed and developing countries, as well as within countries, is politically, socially, and economically unacceptable and is therefore of common concern to all. This was said in 1978. What do they mean? They said, in this world, in developed countries, the people there have got good health care. In the countries that are still developing, they don't have. But even inside countries, people differ. In South Africa, you know already that people who get some form of good health care are those who have got medical aids. And they are only 14% of the population. Yes, they are only 14% of the population. They are the ones who get good health care. Now, the conference in Alma-Ata, with 164 countries, they say that situation is politically, socially, not economically unacceptable. Nobody must accept it. It is therefore of common concern to all. It ended with a slogan, Alma-Ata, health for all by the year 2000. Now, the year 2000 was 22 years away in 1978. You know, I was at UCT some few weeks back, and I said, in 1978, I was doing first year medicine. They were surprised. And in fact, they were so in shock. How can, they thought I was an ancestor, Then I realized why. Many of you who are here, in 1978, your mothers were still being born, which means yes, some of your mothers were born at that time. And me, I was doing first year, so they thought, oh, what is this creature standing in front of us? Yes. Anyway, I was doing first year medicine. We were angry with this slogan of health for all by the year 2000. We were activists like you. Why were we angry? Because he said, why do they promise people of the world good health care only after 22 years? We thought it was too far. We wanted, as students always do, we want it now. When students want something, they want it now. Yes. So we wanted it now. But the bad news is that the 22 years came and went. The situation became worse. Today, since this slogan was declared at Alma Ata, today is 47 years. And we are very far from attaining this. Why? There must be a question. Why will 164 countries all gather in one place, make such a strong declaration, and 47 years later is worse? Are they stupid? Where do they come from? What caused that? That's exactly what I'm going to try and explain to you, how we came to that situation. Because that declaration was not opposed by any country. From there, United Nations met many times. From there, every year, ministers of health go to Geneva. We discuss these things, but they never happened. Why? What are the dynamics? What is the politics? It is because of this. Do you understand why I come into? It is because of this. You can make many slogans, you can make many declarations, you can make many conferences. If you don't correct this, those things will come to naught. So what is wrong with this? To understand it, I'm coming here. There are three methods of financing healthcare around the globe. The concept of financing health, Nina, there's only one method of financing you. It's a bursary or NEFSAS. Yes, but healthcare is financed by three methods in any country around the world. Now, before I go to those methods, I want to show you this. A professor of health economics at London School of Economics, this is this year, he said South Africa should ditch its American healthcare system. What did the professor mean when he said American healthcare system? And he said South Africa must ditch it. What is the American healthcare system? It's not talking about PEPFAR, which Trump took away. He said we must ditch the American healthcare system. Why was he saying that? I'm going to try and show you. It's Professor Robert Yates who said this word. For your information, yes. It was in May this year. So it's only 4 months away. And he was very strong about it. And I met him in London in June. And I asked him why he said this statement. And he explained to me so thoroughly that I was convinced that he's right. Now, the three methods of financing healthcare are there on the street. This is called National Health Account Data Set. They were developed in 2009 by the World Health Organization. What do they mean? If you check here, these are developed countries. And they said the three methods of financing health is number one, mandatory prepayment of health. You know, when somebody is standing in front of you speaking and you hear noise, you think you are talking rubbish. Maybe it's time to sit. Or you think you are irritating the audience. That's what you feel when you stand in front of people and they make noise. You feel like you are saying nothing. So, but if you are saying nothing, stand up and inform me. Don't just make noise. All adults, yeah. Now, the first method of paying for health is called mandatory prepayment for health. It is blue there, as you can see. Mandatory prepayment, what does it mean? Let's look at the word prepayment first. It means health care must be paid for before the person is sick. That's why they say prepayment. Now, let me explain to you right from the beginning. There's nothing like free health care anywhere in the world, except maybe in Cuba. Even in Cuba, you can't call it that. There's nothing called free health care. There's nothing. What we mean by free health care, we simply means at the time you are sick, you are not required to pay. Your health care must be paid somewhere before you are sick. When you are sick, you must be facing the disease, not the money. You understand what I mean? So it's not free. It's just that it's paid somewhere outside the offices of the doctor, outside the operation room, outside the CT's, MIT scan, etc. That's what we call prepayment of health. Meaning countries must prepare that before individual citizens are sick, their health care must have been paid for. And when they say it's mandatory, it means there's no choice. It has to happen to everybody. Now it's represented by this blue. The second method is called voluntary prepayment of health. It also means health care must be paid for before the person is sick, but it's voluntary. Now that voluntary prepayment of health in South Africa, it has got a name. It has got a specific name. It's called a medical aid. Medical aid are not mandatory prepayment of health. They are voluntary prepayment of health. The last one, which as you can see is red there, this. The last one, which is green, is called out of pocket. Out of pocket simply means cash. You can't get into a cafe and get anything without cash. Whether you buy chappies or a cold drink or what, you need cash. Now, it's a type of healthcare system where whatever you need, you pay cash. If you have got flu, you want a cough mixture, cash. If that flu gives you a headache, you want Panado, cash. If your nose is blocked, you need nose drops, cash. If you need some injection, cash. Yes. That's what is called out of pocket. I experienced it personally in Kenya. I think it was 2021 or 2022. And I want to give you this story because it's contrasting. I went to Kenya in the year 2000. I felt very sick. They took me to hospital. And they treated me very well. Very, very well. I had no problems. But fast forward 20 years later. 20 years later. Because what they were treating me under was mandatory prepayment of health in 2000. But in 2021, they took me to a private hospital. I was very sick. I couldn't stand. I had plantar fasciitis, which you'll know later on when you become men and women, because now you are still babies. Plantar fasciitis, yes. Okay, so I was on a wheelchair. Then they put me on that bed. One young girl approached my bed with a speed point. Yes, she had a speed point. She said, doctor, the doctor has ordered a drip. We want to insert a drip on you. You must pay now. Can you swipe? And firstly, I've got a medical aid. He said, no, we don't take South African medical aids here. You're going to pay cash. That is out of pocket. So he said, please swipe. Look, I was in pain. I didn't even ask how much. I just took out my debit card, and they put up a drip. Yes. Yes. No, it's because I've got a debit card. Remember those who don't have, you understand what I'm trying to do. I swipe, then they put a drip. Then another one came later. Doctor, the doctor has prescribed a pain injection. That is the one I needed the most. Can you swipe, please? Then they give me that injection, I relaxed. Then came another one who introduced herself as a physiotherapist and said the doctor has ordered that we must put a pad under your foot, in the shoe, so that it's soft there because you are in pain. Can you swipe, please? Yeah, Mrel, a woman. That is out of pocket health care. And I was saying this to demonstrate to you that it's an impossible thing for the world. Do you understand what I mean? You can't run the world like that, but it's green there. So these are the methods. Now, As you can see, this is Austria, Australia, Belgium. These are countries in what we call the global north. They are developed countries. What about Africa? Here is Africa. They call it a disaster in the making. Yes. The World Health Organization said Africa is a disaster in the making. What did it mean? Because if you check in Africa, the predominant method of paying for health is cash. And what is the disaster about that? The disaster is that in Europe, an ordinary person you meet on the street is having some bit of spare cash. They are not poor people in Europe. There are very few. Is having some bit of cash, but when they are sick, their countries take care of them on mandatory prepayment, right? But in Africa, where people don't have cash, when you go out of here, the ordinary person you met on the street, men and women, they'll hardly have cash in their pocket, or only what they will be having is just for food for that night. But when they are sick, they must pay for cash. This is what they call a disaster. And this disaster has already caused serious problems on the African continent. One of them, which I can demonstrate, is what happened in 2013. Many of you may not remember what happened. Those of you who are old enough, you remember the disease called Ebola. Yes. It affected West African countries. Do you remember the countries? What was it? No ways, not Nigeria. Next. No, not DRC. Well, Ebola started in 1976 in the DRC, in a village next to Ebola River. That's why they call it Ebola. But the one in 2013 was not in DRC. It was in Sierra Leone, Guinea, and Liberia. Those are the countries that suffered. Now look at this screen. Do you see that country there? What is it? Sierra Leone. And this one, Guinea. What is significance about that? Look at their mandatory prepayment of health. Everything is cash. So what does it have to do with Ebola? Because by the time the World Health Organization came to know that there is Ebola in Sierra Leone, it has already spread in the villages very fast. Why? Because the people who caught it needed cash to go and see a doctor. And they didn't have that cash. So they just said many of them died, they infected the others. It spread all over by the time they caught it. If people could be treated without cash, the World Organization will have picked up Ebola very quickly. It wouldn't have demolished so many people. So that's the significance of this disaster. But now I want to go back here. All these countries, as you can see, they are using mandatory prepayment of health, as you can see from those graphs. But at the extreme, there are two countries. It is South Africa and USA. In 2009, the World Health Organization declared South Africa and USA as outliers. They say these two countries are outliers. Naka ke bolela Sepedi, a ke tsebe outlier ka maleme a mang, ke tseba ka Sepedi. And I can simply say, you are an outlier, but that's what they mean. Because you are doing what other people do not do. You are doing your own things. Why is South Africa and America outliers? Because as you can see, their predominant method of financing healthcare is RAID, which is what? Voluntary prepayment, which is what? Medical aid. Every person in South Africa aspires to have a medical aid. Everybody is fighting to have a medical aid. And don't think it's happening around the whole world. This is your thing here. The whole world has got nothing to do with it. In fact, they are doing away with it, as you can see. That red part is you in South Africa and America who are itching for this medical aid, voluntary prepayment of health. Believe you me, it's not a good way of financing health. For the simple reason that it leaves many people behind. No matter what you do, it will never cover many people. At the moment I'm sitting next to you, this voluntary prepayment of health we call medical aid covers only 14% of the South African population. When it comes to blacks, it covers only 10% of blacks. At least in the white community is better, it covers 72%. That's why it's mostly whites who are fighting to keep this system, because it covers 72% of them. Among Africans, it's only 10%. So you can't tell me it's a good method. It's used mostly in America and in South Africa. That's why now Dr. Margaret Chan, she was a Director General of the World Organization. She's from Hong Kong. The present Director General is Tedros Ghebreyesus. Dr. Margaret Chan asked me, he said, Minister, your healthcare system is British. That's true. Now you are here as medical students or healthcare students. What you are teaching you is British, believe you me. Colonization or colonization aside, we are teaching you a British system, because that's what we have inherited from the British when they took over our country. The curriculum we are teaching in medicine is British. The titles of your professors and lecturers are British titles, right? During my time at medical school, when you write a senior exam, after passing MB, CHP, if you want to continue as a specialist, you used to study here and go to write exams in Britain. In Glasgow or in Edinburgh. That's why you see some of your degrees in brackets written FCP or FRCP, Edin and all that. So we are using a British system. Now, Margaret Chan said, having been using this British system for such a long time, at what stage did you become American when it comes to healthcare financing? In other words, you are saying you are using a British system of health, but when you finance health, you go the way of America. That's why Professor Yates was saying we must teach the American healthcare system, because the American healthcare system is not good at all. It has got a lot of money, but that money doesn't reach patients. Just like lots of money. There's no country that is spending more money on health than America. But that money is not for patients. It's for who? It's for people who are running the system. But it's legal, and because nobody sees it as stealing or all that. Now, that's the system that we are following, which we should not be following. But we are. Even here in Africa, as you can see, medical aids are in South Africa and Namibia. We infected Namibia with our system. But the new president in Namibia has made a declaration. I was made to understand he's going to work from April next year. I'm still checking the facts. Where he said it doesn't matter who you are, you all go to public hospitals and you must improve them. No. How? Nobody told me that. Okay. Yo, I'm told off-campus bus leaves at 19:30. So I must rush. Okay. Yeah, now. So there are lots of things I'm not going to show you. Now, the World Health Organization said in order to solve these problems, you will need UHC, Universal Health Coverage. What is Universal Health Coverage? In South Africa, we call it NHI. What is NHI and Universal Health Coverage? It's mandatory prepayment of health. Pay for health before everybody is sick, and don't differentiate between them. Then they say if that happens, you will have enough money to hire doctors. When medical students qualify, they won't be faced with a crisis like now. Why? Why are we having a crisis? It depends who are listening to. Some will say because of corruption. I can't challenge that. There's a lot of corruption. And we are busy arresting people. And we are still going to do so. Oh, yes. If you check what SIU is doing, and I'm inviting you, listen, in 2 weeks' time, you'll see what's going to happen in Tembisa, you'll see. Just write it down. So corruption, we can't allow it because it deprives people. Yes, but now I'm coming here. If you listen to the radio and TV, they are saying, no, South Africa is not ready for NHI, blah, blah, blah. I just want to take you through what you call many countries that has got universal health coverage, but they call it in different names. In England, they call it NHS. That's why I went there. And I met them in NHI. It was introduced in 1948. They did not introduce it because the British were rich. No, it was the opposite. They were responding to the Second World War crisis. You are aware that the Second World War ended in 1949. And those who know history, I know medical students don't love a lot of history. They love mathematics. I love both mathematics and history. In 1948, it was 3 years after the Second World War. If you read history, you'll know that during the Second World War, Hitler, who was the proponent of that war, was hitting Britain more than any other country. So at the end, the British were very poor. They were very unemployed, like what's happening to us. And they were very sick. Then Europe developed something called the Marshall Plan to rebuild Europe after the Second World War. And Britain was asked, how are you going to rebuild your country with people who are unemployed, who are sick, and who are very poor? They told them it's not going to happen. Poor people can't build an economy. Unemployed people can't build an economy. So the British asked, what do you do? Experts said, no. Introduce a system that will cover everybody. That's mandatory prepayment of health. The British introduced it and called it NHS. And up to now, it's 77 years later, the British still support this system. It's South Africans, especially doctors in South Africa, who like celebrating that the British system is collapsing. It's not. I was there. When I was there, they've just injected 29 million British pounds. Not million, billion. That is 700 billion rand. They injected it to keep the system going. And I asked them why. They say there's no better system than this. Many other countries did that because of a lack of time, I'll move. Even Obama in America tried to put something called Obamacare. The official name is affordable health care because health care in America is very expensive. Make no mistake about it. It's extremely expensive. You see, these Afrikaners who said they are refugees, they are going to America. Let one of them get flu, they will come back here. I'm telling you. There, the system doesn't play. It's very expensive. Yes. So Obama was trying to change it. Now, you will say, if a president changes a healthcare system to be affordable, everybody must support it. That's common sense. But it's not the reality of the world. Just like when they say health for all by the year 2000, you'll think everybody will support it. No, it depends. Why have we not reached health for all? Because there are people who affordability of healthcare is not in their interest. Because they are making business with health. What I mean. They are making business with the illness of people. Now, I'm coming to the gist now. If I don't show you other slides, but I've shown you this, you must get satisfied that you understand our problem. This is the situation as it is in South Africa. The World Health Organization has declared, and I told you healthcare financing is not about the budget. They said healthcare financing is about the total wealth of the country, which you call a GDP, gross domestic product. And the World Organization said no, if a country can spend just 5% of their GDP on health. Can you open this for me? Thank you. If any country, because countries are not the same, the World Organization can't say spend so many billions on health. Because some countries are poor, others are very rich. So they calculate the amount as a percentage of the GDP. They said if a country can spend just 5% of their total wealth on health, it is likely to reach even the poorest of the poor. Do you understand what I mean? Yes, the World Health said if your country spends just 5% of its total GDP on health and health services, all the citizens in your country, regardless of their economic status, are likely to get at least a modicum of good health care. Now, where is South Africa? South Africa is here. We have long passed the 5%. Long. We are at 8.5%. Believe you me, that's not peanuts. This is money. 8.5%. What is 8.5% of the GDP of South Africa? Is 570 billion rand. R500 billion. This is not the budget of health. It's the amount of money that South Africa spent on health every day. When you go to see a doctor, every year, I'm happy it shows that you are very watchful, you are listening. I'm happy about that. Every year, we spend this amount of money on health. Whether you go to the pharmacy to buy whatever, whether you go to a GP or the hospital, the total amount of money at the end of the year that is spent on health is this money, which is 8.5% of the GDP. Now, why then, if the World Organization was not correct, why then are we having problems in our healthcare system? Overcrowding, unable to hire doctors, sometimes running out of medicines. What are the problems? It depends who you're listening to. Those who are benefiting from the present system will tell you that no, it's because of corruption. I won't deny that because corruption is there. They'll say it's maladministration. I won't deny that. They say it's incompetence. I won't deny that. But there is one big thing they will never tell you, which, as far as I'm concerned, is the root cause of all these problems. Corruption, incompetence, etc., are just in addition. What is it? The gross inequality, which was spoken about in Alma Ata. If you want to see it, come to South Africa. The gross inequality in healthcare among the rich and the poor is found more in South Africa than in any country in the whole world. Yes. What is the story? Because this money that is spent on health, how is it distributed? 51% of it goes to only 14% of the population. And the remaining 49% goes to feed 86% of the population. Now, the 86%, those are the people who find queuing in clinics, in hospitals, running out of medicine, having few doctors. They are 86% because only 49% of this total is spent by them. This 14% are spending 51%. Now the question is, who are 14% of the population? Unfortunately, I'm declaring myself I'm one of them. And many of you here, your parents are part of this. So it means me and a number of your parents, yes. Anybody whose parent has got a medical aid, you are here. You are here. 14% of the population, what is it? It's about 9 million people out of 63 million. They are the ones who are spending this. Now to show you in short, these are the people. All the teachers, they've got medical aids, doctors, nurses, managers, police, the army, judiciary, members of parliament, president, ministers, etc. Now, there's an argument. There's an argument why your government minister is complaining about this, because this is private money. What you are not told, the reason that private hospitals are run so well, they are not run with private money only. This government is subsidizing them heavily. Yes, this government is subsidizing them heavily. All these people are subsidized to be on a medical aid. And the total amount of subsidy is 70 billion rand. Yes. Yes, it's 70 billion. In January, when we failed to hire doctors and everybody was insulting us, all we needed was 1.9 billion. But 70 billion goes to subsidize those who are well-to-do. Even the president asked me, he said, Minister, because you are running these things, if they ask me, why am I getting a subsidy? What answer do I have? I said, Mr. President, you don't have an answer. Because there's no way we can justify that system very well. It doesn't end here, 70 billion. It doesn't end here. Anybody who's on a medical aid, regardless of which company they work for. They get tax credit from SARS. And the total amount of tax credit is 33 billion rand now. So you add 70 plus 33 is 103 billion rand. It goes to the private sector every year. Where is it taken from? It's taken from the fiscus, which could be going to help the poor. That's why the system must change. Do you understand me? So those who are in court don't want the system to change because this money is going to them. When we say NHI, we want to change this system. It's grossly unfair. Of course, it's unsustainable. Why is it not changing quickly? Because as it has happened in education, because in education in 1976, young people said enough is enough. And there were Soweto uprisings. Then you came later. When was it? Fees must fall. What year was it? 2015 yes, 2015 or 16, fees must fall. So a massive uprising to change the system. And that's why NEFSAS, we kept on giving more money on NEFSAS because you rose up. Now in health, nobody rose up when this thing is happening because patients are individual entities. Patients are not organized like you students in education. The nearest that people fought together was when HIV positive people under treatment action campaign demanded ARVs. From there, no. Any other illness, nobody organized anybody. If you are diseased, it hits you alone and you die alone. Whereas in education, you refuse to die alone. So that's why there's a problem in healthcare. And NHI is trying to change that problem. This is what's happening. In private healthcare, state medical budget, in public healthcare, this is what you want to change. No, it is like this. It's a painful picture, but it's true. It's true. And you know why? What do you mean president of the country? Unfortunately, it is true. They never said he's a president of the country. It's you who imagine so. You are imagining that. I was not even aware that he's the president of the country. But it is not correct, comrades. Whether it points to the president or not, even him, he doesn't like it. So you laugh at this because I told you. He supports NHI. He signed it into law, if you remember, because he doesn't want this type of system. Now, where is our problem? Our problem is, please listen, the people who are benefiting from this system is the cream of the nation. Are the judges, members of parliament, police, everybody who's running South Africa is a beneficiary. Who is not a beneficiary? The masses. And the masses need leadership to change this system. But the masses don't have the information. Even you never had this information about this subsidy. Because even if you listen to speeches in parliament, you won't see it. There's no item in parliament that says government is subsidizing private healthcare for 70 billion. You won't see it. Why? It's put directly in a salary of an individual. Yes. It's put directly in my salary or the salary of a police officer or a judge or a public servant or a teacher. As long as you have got medical aid, it gets put directly there. There's no article which says you are getting part of the 33 billion because they don't give you the money. They just said in your tax you are supposed to pay this much. Don't pay it. Yes. In other words, it's given to you indirectly. Your tax according to your income, you were supposed to pay 20,000 rand. Don't pay it. It's your tax credit. So when you calculate that money, it's 33 billion. Now, why this picture? What is happening? I will tell you what's happening with this money. Let me start here. I want to start with pregnancy and childbirth. Every year, there are 1,200,000 women who fall pregnant in South Africa. Yes. There are 1,200,000 women who fall pregnant. And they need to give birth to normal children. This money, which is huge amounts, treats only 140,000 women. 1,060,000, they fall here. HIV and AIDS. There are 5.9 million people who are on ARVs in South Africa. This money is the highest, is the biggest in the world. This money treats only 350,000. The rest are treated here. TB kills 80% of all the people who are HIV positive. All of them are treated here. There's no private hospital that agrees to treat TB because it's very expensive. At some stage, a person with extreme drug-resistant TB, you needed 800,000 rand to treat them. So those who have got business of health, they will never agree to pay that amount of money. Lastly, childhood vaccines. All of you here have been vaccinated for measles, rubella, and all that. Childhood vaccines. This money pays only for 2% of them. The rest are paid for by here. Contraception. Medical aid don't agree to pay for contraception. They will never. So I can go on and on and on and showing you that this money doesn't do much for the population. That's why these people go to hospitals, overcrowding, etc. There is one hospital, I'm not going to name it because I'm not here to scandalize, I'm just giving you facts. There's a hospital in the center of Johannesburg. There's a hospital in the center of Johannesburg. It has got 57 gynecologists working there. It's a private hospital. It has got 57 gynecologists working there. What is the problem? That number of gynecologists is more than the total number of gynecologists in Mpumalanga, Limpopo, and Northwest added together. They don't have 57, yes, in the public health care system. So which means that 1,060,000, this is gross inequality, and we are trying to stop it. Yes. Now, I want to demonstrate to you, your students, you need to know these things, you are medical students. This graph here, this table compares countries in BRICS. When BRICS was still having, I'm still left with some 13 minutes. When BRICS was still, yes, when BRICS was still having 5 countries, the slide compares the total expenditure as a percentage of GDP. Number 1 is Brazil. They are spending 9.89% of their GDP on health. Number 2 is South Africa, 8.5. We have overtaken Russia, which is much more advanced than us, a bigger and richer country, but we are spending more as a percentage of GDP than them. China, 6.8. China is the second biggest economy after America, but they are still at 6.8. We have overtaken them. India is still in red. They have not even reached the 5%. But what? All these countries have got better health outcomes than South Africa. Yeah, look, start with life expectancy. We are the only ones who are the lowest. Why? Because the money is there, 8.5% of GDP, but it's only going to 14% of the population. It's like having 100 students in a class. If you support 14 of the students out of 100 and you give them everything, they are going to pass with distinctions, but 86% will fail because you are ignoring them. That's what is happening in our healthcare system. As you can see, the only way where all the countries are red is non-communicable diseases. Diabetes, high blood pressure, cancer, they affect all countries. But when it comes to diseases of poverty and infection, South Africa is the worst. Look. No, we are the worst. Because why do you fail to see that? We are taking care of only 14% of the population. Or we are giving all the money in health to 14% of the population. What do you expect the results will be? You know? Now, I want to show you this because it's also important because you are going to be doctors very soon. In 2010, medical aid collected 84.7%, 84.7 billion rand. When I address GPs in the townships, many of them hate NHI. They say it's going to make them poor. I said, GPs, NHI is going to make you poor. You are poor now. Very poor. Yes. No, GPs are poor. I'll tell you why. In 2010, do you know how many GPs are there? In the whole of South Africa, in the townships, in the villages, do you know how many GPs are there? But out of 84.7 billion, in 2010, they got only 6.2 billion. That's peanuts. That's why I'm saying they are poor. They even got less than what you call non-health. What is non-health? It's people who don't touch any patients. They just put people, it's administrators, it's clerks, it's labor brokers. They got 11 billion. Fast forward 2022, 218.4 billion rand was collected. GPs got only 11 billion, but which is 5%. But non-health got 18 billion. So when I say GPs are poor, I'm not joking. It's shown in figures. Why? It's because our system favors private hospitals and specialists only. If you are a GP, forget. And we can't run that system because GPs are running primary health care. Now, is the healthcare system only divided among the rich and the poor? No. It's still very much racially divided. This is 1960. In 1960, when you go to private sector, these are the blacks you used to find. And these are the whites who were going to private hospitals. If you go to a public hospital, these were the blacks you'll find, and a few whites who are lost, who have gone astray. Yes. You'll find them here, sitting with these blacks. That was 1960. It's not surprising it was under apartheid. It's not surprising. Fast forward 2015. If you go to a private hospital, you find this number of blacks and these whites. If you go to a public hospital, you find this number of blacks and a few stray whites. So it means we were not able to change the system, because our healthcare financing system is skewed in favor of those who are rich, and they are mostly white. What are the results? The result is that medical aid, having started in 1967, 10% of black population, but 72% of white population. As I'm standing here, 90% of the black population are not covered, and 28% of the white population are not covered. They form that part of the 86% of the masses. So we need to change this system. These are very technical things. You're still babies, I won't show them to you. Now, yeah, I'm showing you this. This was in News 24. This reverend paid a medical aid for 3 decades. For 30 years, he was paying for that medical aid. He has got cancer. The medical aid is refusing to pay. Instead, they went to his congregation. As I'm speaking to you, his congregation has already paid 850,000 rand. These are poor people. If you emotionally blackmail them and say, your pastor is sick and you need 850,000, they don't realize the people who need 850,000. Yeah. Now, what you hear through the media is this. They'll tell you how bad the public health care system is and it's neglected and all that, but let me tell you some of the strategies. In the Eastern Cape, there's a place called Lusukisiki. Who's from the Eastern Cape here? Kaplan. Okay, you must be coming from the cities, yes. Okay, listen. In the Eastern Cape, there's a place called Lusukisiki. There was no clinic there built by the government. So the Eastern Cape Department of Health had hired the building from Metropolitan Life. They hired the building, they were using it as a clinic. Then they start arguing about rental. how much the Department of Health, rental and all that. And the MEC not being aware that is powerless at that moment. Sometimes when you are negotiating, you must know your limits and your power. He did not recognize his power. He insisted. And Metropolitan tell you, we are going to kick you out. And he told them to go to hell. So they agreed. They agreed to go to hell. And when they left to hell, they took their clinic along with them. And there was no clinic. But there were patients. So the following day, the MEC was scared. He put up these tents for a clinic. You see, there are old ladies there coming to the clinic. You see, there are women. Do you see that these are women? Yes, there are 2 places in the country. I don't know about other countries. In South Africa, there are 2 countries where you won't find men. 2 places, sorry. There are 2 places where you won't find men in South Africa. It's a clinic and a church. You don't find men there. It's a place for women, yes. That's why you see women here coming to a clinic. Yes, women are health-seeking all the time. In 2010, when we launched the world's biggest HIV counseling and testing, after testing 18 million South Africans, 65% were women. 65% were women. Yes. And 5% were children. Men were only 30%. They were not helping us to fight HIV/AIDS, even now. So that's why you see women here. Anyway, let me go back to my topic. So with this is a very ugly thing. The Mail and Guardian went to Lisikisiki. They took this picture, and this one, and they wrote there NHI clinic. Meaning when your government say NHI, this is what they are going to do to you. You think the population will support NHI? They'll believe it's madness and go to the radio and swear and all that. So we went to the Sikisiki and said, no, we need to change this situation. And this is what we put up. It was never, ever shown on any TV or any newspaper. But this was shown immediately. And this is how we are living with that propaganda. Yes, this is the clinic in Lisikisiki. No, so now, do we have an example of what NHI can achieve? Before I stop, yeah. I'm showing you a figure here of maternal mortality. You are medical students, I don't have to teach you what maternal mortality is. But what I want to teach you, maternal mortality does not only talk of the number of women who die in pregnancy and childbirth. It talks about that, but it's an indicator of development. It indicates how good is that country being governed. It shows how developed your country is. If you show me figures of maternal mortality in any country in the world, I'll be able to tell you the type of governance in that country. Because mothers dying in pregnancy and childbirth is underdevelopment. We had that underdevelopment in South Africa because of HIV/AIDS. It was going to women more than men, as you know. By 2009, these are the number of women who were dying. More than 180,000 per 100,000 live birth. In 2010, we launched the world's biggest HIV counseling and testing. That's why we have got 5.9 million people are on ARVs. And you know what happened? Maternal mortality came down dramatically. It was falling. And why was it falling? Because when we launched this project in 2010, there was a debate in the Department of Health which said, no, people who have got medical aid must pay for testing and counseling. They must pay for ARVs. Those who are rich must pay with their money. They must swipe and all that. And we said, no, you can't fight the disease that way by classifying people in terms of income. We said, let's establish a system where whether you are a billionaire, a domestic worker, or a gardener, You test for HIV/AIDS is free. You give you ARVs is free. And that's what we have done. And we are still running that system. And maternal mortality came down. It only started going up during COVID. Yes. During COVID, it went up, but COVID is over, it's coming down again. And this is what we did for HIV and AIDS. And our question is, why can't we do it for all the other diseases? In order to produce this, whether it's for diabetes, hypertension, cancer, why can't we use the same system? As we used to say, the wealth in your pocket shouldn't matter. What matters is that you have got a disease and we need to help you. Right? Now, these are adult things, man. Yeah, no. Let me stop there. The adult things I'll say to them. Yeah. Thank you.
Amanda, comrades, before we go for refreshments and everything, let us first give the SASCO president an opportunity to address you and also to thank the minister for his address. Can we welcome him on stage with a slogan?
This works.
Manza! Viva SASCO, viva! Viva Youth League, viva! Viva PYA, viva! Manza! Comrades, I think in the interest of time, we simply have to thank Minister Motsoaledi, our dear comrade, who took his time out of revolutionary service. Not because it was out of necessity that we were supposed to be here. But we need to thank him because in these days, comrades, I don't want to label them as to which days are these. You will figure it out in your mind, what days are these? In these days, it's quite difficult to get leadership that can come and explain concepts that have to do with shaping our society for the better. As much as I cannot tell you what days are those, but I can tell you why we don't have such leadership. It's because they also don't take interest in learning, reading, and understanding the conceptual journey of our transformation. So we thank you, comrades. You can't be Mr. in this platform. You are no longer a minister. That cap, we throw it out of the door once you are here. We thank you, Comrade Motsoaledi, for this lesson. I feel much more of a better person than I was yesterday, coming into contact with this kind of information. I must tell you, comrades, that what is disappointing about this, what is extremely disappointing about this is that the extremities of moral degeneration in South Africa have even affected leadership. To the extent that there's no political willingness, because it's political willingness that is needed to change the situation that we've been made to see here. Comrades. And why is that the reason? You must know. Why is it that, Comrade Motsoaledi, comrades of the African National Congress to begin with, and the progressives in extension in parliament, They are not leading a revolution in parliament to say, we are going to do away with medical aid in order to pave the way for the entrance of universal health care. Why is that the case? I will tell you why is that the case. Because the leadership in this country has shares in pharmaceutical industry, the pharmaceutical industry. The leadership in this country has companies that are contracted to provide security in these private hospitals. The leadership of this country, comrades, go to the registry of the shares of these private hospitals. You will find your so-called or supposedly revolutionary leadership listed there. That's the reason why, as much as conceptually sound and daring, what we find here, you are not going to find it implemented for the next 3 years. Comrades. But what do we do? Because we are young revolutionaries at the end of the day. We're the ones who can shape our future for the better. We're the ones who can define the trajectory that we are to travel. We are the ones who can put a stop to this. What do we do, comrades? We make it a point that we invite Comrade Motsoaledi to many of our campuses in order for us to learn and mobilize. Beyond learning, comrades, we ought to mobilize. We are mobilizing for the implementation of NHI. That's what we need. On my parting shot, comrades, it is very much understood that tomorrow you are exercising the right that you received and you got, and because it was fought for. Yes. The right to vote for the leadership. The leadership that can create more of these platforms for you to understand NHI. Tomorrow, comrades, you are voting because the leadership that needs to be in power in this campus, in this institution, must understand the necessity of functioning clinics. Must understand that there must be GPs that are employed in that particular clinic of this campus. Must understand that there's a necessity for functioning counseling units. We cannot have many of our brothers and sisters dying because of mental health. If we are to understand NHI in practice, the benefits of NHI in practice, we must understand the holistic picture of our healthcare system. As it has been depicted here, that part of the problems in the context of illness is mental illness. We go through a lot, comrades. Your leadership must understand that there must be an open door for each and every student to access healthcare services free of charge, comrades. No consultation fees in a campus-based clinic. No consultation fees to see a GP on campus. None of that must be applicable to students. And to those that are going to be joining the training group to be general practitioners, they must be supported with stipends. It is important that the healthcare society is funded, comrades. It will not be funded if we do not wage a war against capitalism, because we must put a face to this inequality. The problem for this inequality is capitalism. Capitalism, President Malachi, sells even oxygen. Capitalism sells oxygen for real. You know, when you are going to buy a property there by Kemps Bay, they will tell you we are selling it at this value. But part of this money is because of the site that you are seeing. We are selling you the site that you are seeing, that you can, have a site to the ocean, and it's also sold. You are somewhere in Port St. John's. You can build your own homestead. You are watching the ocean. It's not being sold. Capitalism is ruthless, comrades. We need to wage a war against capitalism, but most importantly, mobilize each and every student on campus so that you go and vote for the South African Students' Congress. Amandla! Viva Sasco, viva! Viva Sasco, viva! Mandla!
Amanda! Comrades, before we welcome the provincial chairperson to introduce the final speaker, I have an announcement, comrades. The announcement is that those of you who are off campus, we have good news. The leadership of SASCO and the ANC League has organized private transport for you.
It's like this. Thank you very much. Thank you very much to the National Executive Committee member of the ANC Youth League, Dr. Mike Ramotwala. In the Youth League, that's why you find doctors that are this progressive. My job is not too long. Baba Rasang after school is after school. My job is not too long. It's to introduce a deputy president of the country. We're saying this because this is the president of the Youth League, or the president of the ruling party, which of course the youth are a majority in this particular country. I'm about to introduce to you a man who fears nobody, that speaks truth to power. A man that has told President Ramaphosa that it is useless to take young people to school and not employ them. In January this year, he told the ANC leadership, including the minister here, that why are we giving our students in SMU, NFSAS, after that we become that government that fails to employ them. While introducing to you the president of the Congress Youth League, a frontline trooper for economic freedom and social change now. During his years, he has fought for free education. He has fought against student exclusion. Ladies and gentlemen, President of the Congress Youth League. Is coming to Makumanda, oh Mama Diegele, oh Mama Diegele, oh Mama Diegele, oh Mama Youth League, Kamalache, Youth League. Kamalate, Zire Palezinja, Awiyo, Zire Palezinja, Iyo, Espame Kwengane, Materela, is coming to Nane. Makumanda. Thank you very much, President of the Youth League, the student of Assembly.
Manja! Manja! Away, two! Away, two! Viva Sasko, 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 Viva! Viva! Niabe Sabana! Niabe Sabana! Watsala! Wirala! Watsala! Viva Sasko, viva! Thank you very much, Chairperson of Gauteng. When you were introducing me here, I was telling Comrade Tamswa lady that it sounds like it's ringing a butcher already, but I'm still alive. I was starting to be worried that maybe I think I'm alive and I'm not alive. But because I'm in the middle of medical practitioners, I think I'm in safe hands here. Comrade Mike, the doctor of the ANCYL clique subcommittee of health, the ever vibrant subcommittee of health. I always say that one of our subcommittees of vibrant is communication, health, and organizing. Those are very busy subcommittees. But comrades, I think mine here is very simple today. Is to energize you so that you wake up in the morning and go and mobilize all students here to vote for SASCO. The chairperson of the branch who spoke here on your behalf, she looks like a person who's going to change lives in this campus. I was very excited, Comrade Mtwa lady, when I saw a young lady addressing you with confidence and authority. Then I knew that the future of the country is safe. Now you must not be lazy tomorrow. You must go and wake up and vote for SASCO so that a responsibility is given to a person like her. With all the weaknesses that the movement is having in our government, but we can confirm that part of the reason we're fully here in this hall, it is because of policies of the African National Congress. With all its imperfection and challenges, if it wasn't for the African National Congress and SASCO and the laws that are put in place, we will not be here in this hall today standing here. And with all those weaknesses, we must acknowledge that the ANC really tried to intervene. Because most of us from very poor backgrounds will never have an opportunity to go to a university if the laws in place do not allow that. Now, comrades, with all the weaknesses like any other house, le matata lona auto fruwa paka warwa spela ka gaya o sa boa ka wane maobane zanke ba reka cold drink mara maloba e rekile. Now o gopola matjatjana cold drink mara o gopole hore mokgatlo wa the African National Congress under SASCO with all its weaknesses is continuing to fight for the students to have access to education. And what we are fighting for, we are not fighting for NEFSAS. We are fighting for access to free education for all. There must not be anyone. Already black people are in trouble. Already we have no dignity. Already we are dispositioned from our economic activities. Already we are faced of poverty. Can you imagine, Comrade President of SASCO, that now you must explain yourself every year, how poor are you for you to study? We're saying no one has to prove how poor they are for them to study. If you qualify for a course, you apply for it, you get, you enter, you start. This many days of affidavits, where you must prove how poor is your grandmother and your mother, for you to access education must go to an end. The ANC has promised you free education for all. The ANC never said you must prove how poor are you to education. We must take from the rich and give to the poor. We must tax the rich to fund education. Why are we protecting the rich who are stealing our minerals every day? We are protecting them every day. They take this money here to go and build their own countries at the expense of our people. We are saying those who mine here, who take our minerals every day, who exploit our people, they must use that money to fund education in this country. We don't want excuses. We are saying NHI is now an act. Those who are in court must be in court. While they are in court, you comrades who are deployed by the people of South Africa, don't fear white people, white males who are in court. You fear them. You can't fight them under apartheid and fear them under democracy. How do you sacrifice yourself under apartheid to fight a system of oppression? When you are in power, you are still complaining like you are not in power. We are saying, Comrade Aaron, don't fear to implement policies of the ANC. Implement all resolutions of the ANC, including NHI. Encourage people to wake up in the morning. When they are sick, they must go to the nearest hospital next to them. Whether it's a private hospital or a public hospital, all hospitals in this country must be declared public because of NHI. There are people that we fear, that we don't know them, Rena. They are feared, but we don't know them. Minister Balla mu minister, mukule minister Allah. Regasbel minister Allah ngerlogon, walla minister liet. Ralla le Rena, le minister walla, rella kamuka. Kanike manke tapilina. Everyone is crying. Now we must easily confirm to you that when you vote for SASCO here, you must not vote for a SASCO that is going to be led by SRC that is crying. We want an SRC that will hold management accountable, that will make sure that students are serviced on day-to-day basis. Arnage SRC, ya not TL management, tagere. Marako SRC than resolving issue of land of students, but not TL management. We want an SRC that will be selfless and be ready to fight for the interest of students. You are here today until this time because you believe that you must listen to leadership. You got a very educational presentation from the minister, Dr. Mtwaledi, who educated you about these challenges. Use that information to mobilize society against the ills. All of you here are doctors. I can imagine in your village, but there is an unemployed doctor. An unemployed doctor. An unemployed health practitioner. Now gangsters now are richer than those who are educated. Now it means that it's clear that you are no longer going to be role models in your townships and your villages if you are not affirmed and employed by the system. It must be automatic that when you graduate here, you immediately know where you are going to work. You must not even apply. You must know when you live here where you are going to work. Because our system is clear that you don't have enough health practitioners again. Now you can't say you don't have enough health practitioners in hospitals, but you have unemployed doctors, unemployed nurses, unemployed, everyone is unemployed who's educated, who's supposed to assist the system. Another issue coming to our lady must resolve is the issue of illegal foreigners. The illegal foreigners are heavy on our infrastructure. Our doctors are overworked because of illegal foreigners. Our infrastructure is collapsing because of illegal foreigners. The reason it's collapsing is because you can't budget for people you don't know if they're here. Because if you are illegally here, the government does not know that you are here. Now, how do we budget for you when you don't know that you are here? And the human rights will not allow you to turn back a person into be inhuman. Now, the most important thing, Comrade Aaron, on your Home Affairs Minister, you did a white paper on how to take care of our borders and manage illegal foreigners. We're saying these doctors, because they're going to be employed immediately when they leave here, because the current government of the ANC must make sure of that. They must not be overworked in hospitals because of illegal foreigners. Let's close our borders and secure them. Everyone in this country must be the ones that are accounted for. Secondly, before you employ a foreign doctor, you must check that are the South African doctors who are not working. Because how to start with a foreigner before you start with the one you have in the house? Now, in the implementation of NHI, it must be fully implemented by your own doctors you took to school. Others you took to Cuba, others you took all over. But after you invest in them, you leave them to be unemployed and you employ foreign doctors. We must first start with the locals first. When they are all employed and working and there's a demand, you can start looking for foreign doctors. You don't start by foreign doctors and leave the local South African doctors hanging on the streets while foreign doctors are working and they're unemployed. That system, it is not sustainable. We're saying that is a system that must be changed urgently. All South African educated doctors must be employed. The allowances that you give them here, you must give them allowances like people who are studying serious courses. Colin Malachi, who's doing a BA, can't get the same allowance with someone who's doing medicine. There are serious things here. Those who are doing here in Medusa, people here in Medusa, Comrade Nsako, they are very serious people here. Now, I can't get the same allowance as a medical doctor, medical practitioner. These people are doing mathematics. What they are doing is a calling. Now, they must see it as being a career above many, so that we attract many people to do these careers. Now, we're saying that when we engage the president, let's increase the allowances of students who are doing medical practitioners. It is very important that they get more than those who are doing these things of mine. Now, as we conclude, voting SASCO is compulsory. We must defend this university against criminals of the EFF and many others. We must not vote for criminals of the EFF, we must vote for SASCO. SUKA was formed by the ANC, but people are abusing it here wrongly here. Kamakala ore organization ya baruti ya oswalu SUKA isore ke matawa ka munja pola music. La ibona ihijakiwe. How do we allow a Christian organization like SUKA be led by drunkards here outside who are playing music, getting drunk when there's meetings here? Now it's clear already. That is not our SUKA. Now doctors can't vote for those drunkards. When you have a proper leader here who's very strong. Now every time you see EFF, you must see criminals. When you see SUKA on the ballot, you must see drunkards. When you see SASCO, you must see leaders. Thank you very much. Thank you very much.
I'm going to put it on you.
I don't know. That would work.
That was very powerful, right? I think we could all agree. Before we can close, the minister would like to take 5 questions. So can we please note 5 questions, and then the minister take notes, and then we make an announcement about the refreshments, and then we leave. So 1, 2, 3, 4. But it's 5 questions, but I see more hands. Okay, those that want to ask questions, please come. Please come and stand. We're not going to pass the mic. You can come. Those that have questions, please come.
What am I doing with this? I'm holding them like this.
Finished.
Whew. Oh, I'm correcting. Amandla, comrades! Amandla! Amandla! My name is Samantha Maklase. I'm a final year dental student. My question for today for you, Minister, is that we have a dental building here, and it is currently the biggest dental clinic in South Africa. So in that clinic, we work from 8 o'clock until 5 o'clock or past hours. Our supervisors are apparently being paid by the Department of Health and not the school. So the Department of Health has cut their costs. So now they leave at 3 o'clock and we are left alone in the clinic, either to leave patients or to work alone and not get marks after that. So my question is, if the Department of Health has been paying these doctors, these supervisors, for all these years, what is the school doing with the money that we are paying them for our education? Another thing is, in dental, our chairs are not working. In clinical years, we have BOH2, BOH3, BDT2, BDT3, BDS3, BDS4, and BDS5. All of us are sharing chairs that are not working. We get there in the morning at 8 a.m., patients wait for us in those chairs, and we are fighting for working chairs. So, my question is, what is the Department of Health doing, and how is the Minister of Health helping them? Thank you.
Where must I point? When I move this thing, where must I point? Yeah, perhaps.
Thank you very much. Thank you very much. I think the previous speaker has amandled enough for me, so I will not delve too much into that. I'm seeing that the minister was just saying now. Oh, sorry. My name is Comrade Annie Taluza from Inner City Central.
Annie?
Yes. Thank you. My name is Comrade ANCYL from Inner City Central. So seeing that, Minister, you were saying that you were a bit tired, I will just limit my questions to just two. The first question is, a significant public health perception, especially among middle income earners, is that NHI will function as a new tax that further reduces their disposable income. Given that winning public trust is critical for the success of NHI, what specific strategies or messaging does the department have to ensure that it wins perception of the community members where the NHI is supposed to benefit? My second question is, one of the core issues in healthcare is the unemployment of healthcare professionals. Will the NHI assist in reducing unemployment in the healthcare sector, and most importantly, how? I think that's all. Thank you.
Thank you. Minister, my name is Lerato Mrashwa from the Department of Virology. My first question, Minister, is I would like to understand what is the core issue that hinders the NHI project to be initiated already? And what is the core issue that hinders this project to be initiated already by now? And then how will the government engage with health institutions that initiate this bill? How will the approach be about? And also, will the bill be applicable to health institutions like those organizations like Borders with Doctors? Will patients be able to consult there under NHI bill? And then lastly, how do you see us as a community helping this bill to succeed? Thank you.
Greetings, Minister. Greetings, Minister. I think I'll keep mine as short as possible, since sound projection. You can hear me, most guys. How? Okay. I'll keep mine as short as possible. So, Minister. Yeah. Okay. Can you please hold it for me? Okay. Thank you. Minister, okay.
Name first.
Okay, Tsepo, one of the students here in Sefako. Tsepo Ntlemeza. Yes. One of the students here in Sefako Makhatho. Guys. Okay. So Minister, given the scale of health inequalities here in South Africa, how will the government fast-track certain critical services of the NHI, given that it takes 14 years for it to roll out? And will the necessary infrastructure be in place when that time comes? Because there were talks of tertiary tertiary health institution being present at that time. Will they be available? Yeah.
Greetings, Minister. My name is Comrade Lian, final year physiotherapy student here at SMU. Lian. Yes. So my question to you, Minister, is that when we get to study of NHI, it tells us that its way of ensuring equality to the people, it is through enhancing the primary healthcare services, right? So now, the question is that what initiatives are there in place in a curriculum setting to ensure that these students, the future healthcare workers, are prepared to then meet the requirements of NHI? Because clearly, currently now, those who are in the working place and at the rurals where the primary healthcare is, they are really unsatisfied about the service delivery that is there and the availability of equipment. So now the question is that what initiatives are there to counteract all of those complaints that are there to meet the requirements of NHI? Thank you very much.
Thank you. Thank you very much. I must start by saying, they want this also. They must hold this also. Yeah. One thing I must state, because I told you, the concept of healthcare financing is a little bit complex. You won't understand NHI in only one meeting. Yes, that's why we need workshops and all that, because it's a very difficult concept. Now, Samantha is raising issues about staffing here, which I did not know about. Remember that the Department of Health or medical schools are not like other universities, because the lecturers in medical schools are serving two functions. Firstly, they are teaching students, but secondly, they are treating patients at the same time. So if you are a lecturer in the Faculty of Law or Engineering, etc., you are hired by the university. But if you are a lecturer in medicine, you do operations, you treat patients. So your employers are two. It is national department, it's the provincial Department of Health and the university. Now, one anomaly which we are trying to fight in NHI, which is a serious anomaly, is what is happening to your lecturers. And that's why she's mentioning this problem. Because we have provincialized healthcare. We federalized it. ANC wanted one national government. Yes. But unfortunately, during negotiations, some people put for provinces, and now they are provincializing, federalizing the whole government. So the result is that when you are a lecturer in medicine, whether in dentistry, physiotherapy, etc., when you are here in the lecture hall, you are in the National Department of Education, which is national. When you leave this lecture hall, you get into the ward, you are in the Provincial Department of Health of Gauteng. That anomaly is not good. So in the NHI Act, if you check, we are saying all the universities and teaching hospitals must be national competence. Because this battle we are talking about is a provincial thing now. I did not even know about it. So we are saying in the NHI, a hospital like George Mukari, Steve Biko's, Groteskiri, etc., they must all be elevated out of provinces. They must go national and be given autonomy. What do I mean by autonomy? The CEO in this hospital ought to be able to run things, not to rely on provincial government. So it's one of the things that we want to cure, to correct the issue that Samantha has shared here. Because she said, what is the university doing? And your chairs are not working. Yes. Where is, you said your chairs are not working and all that. And those are dental chairs. So what is it speaking? Why is this thing not fast now? Yes. Your question was answering this. Essential medicine and other commodities. That's what you are talking about. It means it is that building block that is suffering. And you are asking me about it now. Most of the questions that we have asked are actually answered by this. Yes. Gross inequality, where money, lots of money are going to only a few people. That's why I insisted on it, on that slide. If you won't change it, you'll keep on asking these questions forever and ever and ever. And the president of the Youth League will consider the minister as crying, like you're doing, because we are running in a wrong system. Yes. Annie, the middle class say NHI is going to tax them. Of course, that's the propaganda that's being run. It's a scarecrow to scare people away, because they say NHI is going to be expensive. I want you to understand why they are saying so, because it's not true. What is expensive is the present system that we are running now. It's not NHI. If you look at NHI, we want to change the present system, which is very expensive. I'll tell you why. If you want to know how expensive this system is, just go to a private hospital and see what happens. I'm going to give you an example. Please listen carefully. I'm going to give you an example. Why I'm saying they are lying when they say NHI is going to be expensive. What is expensive is the present system. Let me choose a simple thing. A circumcision. Yes, a circumcision. If you go to a GP in a township and ask for a circumcision, they are going to charge you 1,800. Yes, and do a circumcision, and you get out, you are okay. If you go to a private hospital, you are going to pay 18,000 rand. No, it's true, and we do have the figures there. You are going to pay 18,000 rand. In 2010, I went to Eswatini, it was still called Swaziland, for a meeting of ministers of health in SADC. When I arrived there, the minister complained bitterly. He gave me an invoice. Eswatini is a small country. There are lots of things they can't do. So they refer patients to South Africa. But unfortunately, they were referring to private hospitals. So he showed me an invoice of a patient who was referred from Swaziland to a private hospital in South Africa, here in Centurion. They did the laparotomy on that patient and charged him 500,000 rand. That was in 2009. They charged him 5,000 just for a laparotomy. And now he said, Minister, we have paid this money. Our problem is the patient complicated. They want to repeat the laparotomy, but they say they want another 250,000 rand. It is their complication. They were supposed to have corrected it. So it's 750,000. Who will pay 750,000? Just for a laparotomy. Now, 2 weeks ago, I was in Zambia for a meeting of World Health Organization Africa region. The minister called me to his office, complained about the same thing, about the expenses here. I showed you that priest there. He's from Quebec. He has got cancer. They say they want 1.4 million. It's not true that the cancer he has needs 1.4 million. It's what they need in the private sector, if you understand what I mean. Now, how does the private sector charge 18,000 rand for a circumcision when a GP charges 1,800? It is the way the system is arranged. And in NHI, we want to change that system. In what way? Let me give you an example of England. You are not allowed in England to go and see a specialist or go to a teaching hospital like George Mukari here if you did not go through a GP or a clinic. They don't allow you. Why? Because some diseases can be treated by a GP with MBCHP and it's okay. Here in South Africa today, a flu, an ordinary flu, is treated by a specialist. You know specialists who are teaching you professors. They've trained for 13 years. Do you need that person to treat the flu? Trained for 13 years to treat the flu? No, it's a curative healthcare system. So in a private hospital, when you go to do a circumcision, number one, they will look for a urologist. He trained for 13 years, he's going to charge you. It's not going to joke. Number two, they are going to look for an anesthetist. Another specialist who trained for 13 years. Number three, they will look for a doctor like me, MBCHP. 3 doctors, all sitting on a small penis of a baby. Yes. Yes. No. Shh. No. I'm giving you facts. All sitting there. Because this is a baby, 6 months old, you know, with circumcised young children, 10 years old. You have got 3 people, 2 of whom trained for 13 years each, just to sit and do that small penis. And it's 18,000 rand. Then they'll charge you for oxygen, for every swab. You remember my story about Kenya. where they say injection, what you call a pet below a that is not healthcare. And that's the present healthcare system. Remember, let me give you an example. If you are in a private hospital, in theater, they are going to do an operation. They put up a drip. If it fails, they throw the needle away. They charge you for that needle. Of course, they charge for everything. If they take a piece of cotton wool, wrap, they charge you for that. Then they count. If theater time is 30 minutes, they charge you for that. You are not in charge of those things. They charge you for oxygen. They charge you for theater time. That's why it's expensive. Under NHI, all we'll say is, if this woman is pregnant, we need to do a Caesar. We need this much, full stop. Under this present system now, I don't know whether you don't know about it, women are no longer delivering babies naturally. They all deliver by Caesar. Why? Do you think God has changed natural birth? No. The reason that they are delivering by Caesar is because a Caesar is more expensive than natural birth. And in natural birth, you are going to sit there for 8 hours supervising that woman. They don't want that because it's a money system. That's what you are going to change in NHI. So what they do in England, they register all the patients and they say, choose your GP. When you are sick, that's the person you must go to. If he treats you successfully, there's no problem. If he refers you, then it's then that you go to a specialist. Not the present system. In fact, because of your age, you may not know. When I was at medical school in Natal, you will never go to a teaching hospital or a specialist without being referred. You will never. That was not allowed. It changed with time. Now, I was telling some lawyers who did not understand. In the legal profession, I'm sure you know that, in law, when somebody has stolen your gold, you don't go and hire senior counsel. Yes. You don't go to the high court, you go to the magistrate court, where there are prosecutors, junior prosecutors, and they see that case. But in health, you go up there, and it becomes expensive. Then the issue of paying cash. When you charge people cash for health, it becomes a perverse incentive. You just charge even for things that are not there. So people who have got medical aids, and I know it for a fact, there are investigations which they do to you which are not necessary. Because you have got a medical aid, they just take blood, they put you this. I told you some people, some pregnant women are put under a scan to see the sex of the baby. That is for money, it's not for health. So under NHI, we are not going to allow those things. We're not. So NHI is definitely not going to be expensive. There's a question here about primary health care at the end. I want to start with it. What does primary health care mean? Because NHI is also going to be primary health care. What does primary health care mean? Many people believe it's inferior health care. Primary health care means 3 things. 1, prevention of diseases. 2, promotion of health. 3, when you are sick, you go to start at the bottom, not at the top. That's what primary health care means. Many people here believe primary health care is a clinic. No. Prevent diseases and promote health. That in itself is primary health care. Immunize people. Immunize children. For instance, I'm going to give you an example. How many of you here, girls, I'm asking you because we started in 2014. How many of you here have received your HPV vaccine when you were 9 years old? HPV vaccine at school. How many of you received it? Yes. Shh. Why were you Why did we give you an HPV vaccine? Because it's primary health care. When you turn 30, we don't want you to get cancer of the cervix, which is the second killer of mayors. At the moment, sorry? For what? Okay, fine. Let me finish. Yes. But In the present system, you don't immunize girls to stop them from getting cancer. You allow them to get cancer and come and charge them. As I'm talking here to you, we started giving HPV vaccine in 2014. We've vaccinated 6 million girls as I'm speaking. All of them are not going to get cancer. And that's what NHI means. Yes. Yeah. Shh. Lerato, what stops NHI? Shh. Why are we not implementing NHI? Number one, there are 7 court cases. We are in court now. People have taken us to court to stop NHI. But number 2, the president only signed the act into law last year, if you remember. You don't implement the law unless you have got regulations. We have just completed regulations. We send them for public participation. That's what the law says. We have about 3,000 inputs. We are studying them. When we finish studying them, we gazette them and we continue implementing. That's what we are doing now. Unless, of course, unless the judges stop us and say don't implement NHI. How do we fast track NHI? Shh. Somebody here very brilliant mentioned 14 years. NHI is not an event. It's a process. It's a lifelong process. In England, they started in 1948. Even now, they are still implementing. You will never come to an end of implementation because you change. Why? Because human beings change, diseases change patterns. You can put benefits under NHI, and the following year, a new disease which was never known comes in. You have got to change. So NHI is going to be ever evolving. It's never going to be static. You won't say we're finished implementing NHI now. That's not going to happen. It's a lifelong thing. Yeah. Yes, Leanne. Leanne, you asked me, you asked me about primary health care. You are already being taught primary health care now. You are. You don't need any new curriculum for NHI. Yes, you are being taught primary health care. But unfortunately, the system under which you are now doesn't allow you to do primary health care. Do you know what I mean? Yeah, I'm going to give you an example. When you live here now, you go to work, you are going to treat people differently. Somebody who has got medical aid, you are going to give them a different treatment from an unemployed person who doesn't have medical aid. You are going to do so now. In which textbooks do you find that? Is there any textbook that you have read that say we are now teaching you cancer of the esophagus? And they describe the disease, the epidemiology, and when they say treatment, do they say for millionaires or for people with medical aid, this is the treatment? For domestic workers, this is the treatment? No. All your textbooks, whether it's medicine or nursing or physiotherapy, it shows you one course of treatment. But when you live here, because of the present system, you are going to start differentiating between people and give some good health care and not give others. So there's nothing new we need to teach you. All we need to do is to change this system, which the president said is caused by capitalism. That's all. Thank you very much.
Who's going to close? Let me close, Chief.
Comrades, Amandla, awethu